I'm Andrea. Thank you so much for inviting me to give this talk about treatment. And I just want to share my screen. Let me see if I can do this correctly here. Can you guys see this okay?
Yes, I'll let you know. Just there. Yep, there you go.
Wonderful. So thank you so much. It's really a great honor to talk to all of you today about treatment updates and migraine and what we're thinking about in terms of the pipeline and medications. And hopefully I'll have enough time for questions and things at the end as well. Um, and I don't really have anything, from a financial disclosure standpoint or relationship standpoint for any of the medications or devices or anything that I'll be talking to you guys about today. Um, and I wanted to give just a basic approach about how we think about treating migraine headaches or migraine attacks. I'll talk about the abortive strategy for treatment of migraine. So, how we treat the headache pain when the pain occurs, how we think about preventing the next attack, so stopping the next attack from coming, and then some thoughts about medications in the pipeline. So, how we're approaching things for the future to try to lessen the disability associated with this terrible condition. So, headache disorders. We know that it's a major health problem. We certainly don't have enough researchers or enough funding going towards dealing with this health problem or this health issue. In terms of the problem, the global burden of disease study has actually summed it up quite nicely. Migraine is actually the second leading cause of worldwide years lived with disability. So, across the entire globe, you're talking about the second leading cause of people living with significant or severe disability caused by this particular condition. And so that really highlights the fact that we need to pay attention, right? We need to sit up, pay attention, and figure out ways to treat this condition so that people have less disability and more function. Chronic headache is where patients will suffer from 15 or more days of headache attacks. It's really an arbitrary line in the sand when we say 15 days of headache. It's what we use to think about certain types of treatments like Botox, for example. That occurs less frequently. About 1.7 to 4% of the world's adult population will have a chronic headache disorder, but it accounts for severe disability in this particular population that suffers from chronic headache. So, when we think about treatments for migraine, what are the concepts that we want to think about when we're trying to treat migraine attacks? The first thing that we want to think about is the actual individual, right? We are treating the attack, yes, but we're also trying to treat the patient. We want the person that is suffering from the migraine attack at that time to return to a normal function, right? So we have to think about the individual. We have to understand the needs of that individual as well as the expectation that function will be restored. And we have to meet the challenge of being compassionate. And also, we have to meet the challenge of achieving pain freedom, right? Not just lessening the severity, which is a goal, but actually achieving pain freedom. And we have to think about other concepts as well, like how do we impact quality of life? So, those are the types of things that we need to think about. So again, these are some of the goals: alleviate suffering, provide fast relief. We want the relief to be rapid. We want to restore function. We want to reduce disability. We want to optimize self-care, right? We want to make sure that patients have the flexibility to be able to do what they need to do when they need to do it so that they can get back to the activities that allow them to get back to normal functioning. And we want to minimize side effects, right? There's no point in saying, take this medication if we know that it's going to cause somnolence and they're not going to be able to work and they're going to miss multiple work days, for example. that may not be an effective strategy for some patients. So those are the types of things that we need to think about. So there have actually been people that have looked towards asking patients what types of things are important for them in terms of strategies for treatment. This is important, right? We can't just come up with these concepts on our own. Patients must tell us what things are important, right? So when patients are asked about migraine attacks, they report that the things that really cause problems in terms of the way that we treat migraine headaches is that the pain relief takes too long, that the pain isn't completely relieved, that if we give someone a medication, it doesn't always work, or that the headache comes back, or that there are too many side effects, right? These are not things that we're not all familiar with. These are things that we tackle all the time. So it's important to know that these are the most common reasons for dissatisfaction with our acute migraine attack treatments. When we ask about what could we do better to help with the migraine attacks, well, treatments that provide complete relief, where there's no recurrence, where the relief occurs very rapidly, right? The complete opposite of the things that we're not doing so well with. So these are the types of concepts that need to be folded into our treatment strategy. So complete relief, rapid relief are the things that we want to think about. So when we approach treating migraine attacks, there are some concepts that are important. The first is that we want to treat attacks early, and this is for acute treatment. So when we're treating an attack with as needed or abortive medications, we want to treat early. We want to choose the medication based on the attack severity and the likelihood of disability. And we want to use combined treatments when needed. So for example, you can combine a triptan with an NSAID if the attack is severe. And we want to consider preventive strategies, both medication related and non-medication related, when the attacks become frequent, right? Or when the attacks become disabling, even if they're not as frequent. We want to think about when to start preventive strategies to reduce the frequency of headaches. What are we targeting when we think about abortive and preventive medications? Well, we're trying to target pathways that we think initiate migraine headaches. And one potential strategy is to look at some of the neurobiology of migraine and try to think about where along the neurobiology can we actually target to reduce the likelihood of developing a migraine attack. So how does a migraine attack actually occur? Well, one theory is that it starts with brain excitability, either brain excitability along the cortex. Oh, I'm sorry. I think Jennifer's iPhone needs to be muted. Sorry. I think it starts with, the one concept is that it starts with excitability along the brain surface or in other areas of the brain that are deeper, such as in the area of the hypothalamus, which is a deep structure within the brain. Excitability in these regions are thought to lead to activation of pain sensing fibers or nociceptors, particularly in certain areas like the trigeminal system, which is a system that actually senses pain in the head and neck. And activation of these pain sensing fibers can actually lead to release of certain proteins like calcitonin gene related protein that actually signals pain in the periphery and in the central nervous system. So when we think about mechanisms to target, we can target the brain excitability, we can target activation of these pain sensing fibers or these pain nerves. We can target release of these abnormal proteins that signal pain like CGRP. We can target the inflammation that occurs after activation of these pain sensing nerve fibers and the inflammation that occurs in and around the coverings of the brain. All of these various mechanisms of migraine are all potential targets for both acute and preventive treatments. So this is really the target for a lot of the drugs that we currently use and those that are within the pipeline. And it's also the target for some of our neuromodulation as well. When we talk about neuromodulation, we're thinking about either shutting down nerves, reducing excitability, reducing inflammation, decreasing neurotransmitter release, or release of these abnormal proteins, and decreasing excitability of the system itself. So that's kind of the strategy that we use for the treatment of migraine. So I've already talked about these two different concepts, one being abortive treatment and the other being preventive treatment. So abortive treatment is really when we're trying to reduce the pain intensity and achieve pain freedom when you have the migraine attack. So what we want to do is alleviate the pain when it starts. Think about these as painkillers or pain relievers, and these are really your as needed medications. These are medications that you do not want to overuse, right? You don't want to use them very frequently. They're only used as needed. The preventive treatments, on the other hand, are used for patients that have headache attacks that occur more frequently. Typically, we start to think about them when the attack frequency is about 4 headache days per month or more, or when it's infrequent but very severe or disabling. And these medications are usually daily medications or medications that stick around in the system for a prolonged period of time. And they're used to decrease the headache attack frequency, so decrease the likelihood of developing the next headache attack. So some of the acute treatments can be either less specific or more specific, and these are the medications that have been around for some time. There are medications like non-steroidal anti-inflammatory drugs, which I'll talk about. These are less specific medications, things like ibuprofen, Excedrin, naproxen. There are medications for nausea and vomiting that we can use. There are other more specific medications, and by more specific, I mean those that have been used mostly for the treatment of migraine. In other words, they really aren't indicated for any other condition, for the treatment of any other condition other than migraine attacks. And these are medications like dihydroergotamine or DHE, your triptans like sumatriptan or Imitrex, and there are other newer medications like ditans or gepants, which I'll talk about as well. So non-steroidal anti-inflammatory drugs, or NSAIDs. These have really been a mainstay in pain treatment. They reduce inflammation. They decrease the release of certain inflammatory molecules like prostaglandin, for example. They can decrease inflammation non-specifically. So if you have arthritis pain, for example, you can use an NSAID. So these are non-specific in nature. They work quite well, and they can be used in combination with triptans. The major issue here is that if you overuse them, you can get GI upset, you can affect your kidneys, right? So these are not medications that you want to use very frequently. You can get bleeding as well if you overuse them, but they can be very effective to target one of the components that I talked about that's involved in migraine pain, which is inflammation. The triptan medications are really the core, I think, up to this point of acute migraine treatment. This is the prototypical migraine-specific medication. There have been multiple really well designed clinical trials that demonstrate efficacy of triptans for the treatment of migraine. Some of them are longer lasting, some of them are more rapid in terms of their onset and duration. And there are different formulations of triptans. So those of you that have used triptans in the past, you may notice that some of them, work rapidly, some of them take longer to work. And which one you use may really depend on how your migraine headache, how the migraine headache presents itself. And so there are different types and different formulations like sumatriptan or Imitrex. rizatriptan or Maxalt. And like I said, they differ really in how fast it takes for them to start acting and how long it takes for them to act. So their duration of action and how rapidly they provide relief. If the headache lasts for a long period of time, so you sort of have this slow buildup and it lasts for a long time, and you're likely to get another headache, in other words, the medication wears off and you're likely to have another headache, then maybe you choose a longer acting type of triptan, like frovatriptan or naratriptan, for example. If the headache isn't so long lasting, but is really severe in the beginning and you want something that provides rapid relief, you can tolerate the triptans fairly well, maybe something like rizatriptan might be an option. So that's how you play around with some of the triptans. And oftentimes you may try a triptan and it may not work for the first one that you try, so you switch and try another one. Switching from one triptan to another is not atypical. It is sometimes worthwhile to try different triptans to see how you react, because they do have slightly different profiles in terms of their duration of action and tolerability and potency. Okay. So, some newer medications. Well, lasmiditan is a newer medication. It targets a slightly different receptor. The triptans target a serotonin 1B, 1D receptor. That receptor is located on blood vessels and nerves. This targets the 5-HT1F receptor that's mostly located on nerves. So some of the concerns about the triptans were that they cause a mild constriction of blood vessels because one of the receptors are located on blood vessels. Because the 1F receptor of serotonin is mostly located on nerves, this had less of a blood vessel effect. And so some of the initial concerns about the blood vessel effect of triptans really led to the development of this medication, which was lasmiditan, for people that may have vascular disease. This medication does produce some sedating effects. There's some driving impairment, so it is a controlled substance because of the sedating effect of this particular medication. But it doesn't have the vasoconstrictive concerns that the triptans have. So this is one of the newer medications that are out on the market, and there have been clinical trials that demonstrate efficacy of this medication. Here's another group of new abortive medications for the treatment of migraine. These are small molecule blockers for CGRP receptors, okay? Remember, I talked about this pain protein, CGRP, that's released by nerve pain fibers, right? And so now we have an ability to target its receptor with these small molecule blockers. You may have seen commercials with Serena and a host of others with these particular drugs. Nurtec is one of them. Ubrelvy is the other. Rimegepant, ubrogepant. These are the G pants, and they target, again, the CGRP system. They have proven efficacy. So if you look at the clinical trials, patients had pain freedom after 2 hours when taking these particular medications. They also improved the most bothersome symptoms that accompanied the migraine headache attacks. And so these were proven to be effective in patients in clinical trials. So again, in addition to the ditans, the lasmiditan, here are two other new medications for the acute treatment of migraine attacks. All right. So other options, talk about opioids, we talk about barbiturates like Fioricet, Fiorinol. What I will say about these are they should be used really under only very select situations. In general, these are medications that I tend not to use unless it is really necessary. Sorry about that. Unless it's really necessary, and only under certain conditions. They can produce respiratory depression in some cases, so it's very important to think about that And they can produce opioid-induced hyperalgesia and dependence. So it's really important to think about those things as well. So really, they should not be used as a first resort. In some people, Fiorset can be used, but I would use that really in a limited fashion. They're not first line for the treatment of migraine, and so they really should be used in a limited way. So what about prevention? What about the medications that are taken every day to reduce the frequency of headaches? And what can we say about preventing migraine headaches? Well, what I will say is that this is really a discussion, right? It is a discussion that requires a relationship with patients and an understanding of what types of things they're considering and what kinds of things they want in terms of preventive therapy. And it's not always about medications, right? It's usually a complex consideration before you get to a decision about even starting a preventive therapy, let alone selecting which medication to start. And there are a host of things that one can do in addition to just medications, right? That you guys are also hearing about today. I like this, I won't read out the quote, but I like this particular quote that was from an article in the New Yorker. Dr. Gawande followed one of our headache medicine specialists at the Faulkner Hospital, watching the practice, and they talked about this incremental care of patients, and really it really is, it can be an incremental care, going from one medication to another, and it can be a very trying process. And so we really do require sort of a synergy between the physician and the patient, and to be able to go through this process of trying to find the right strategy for treatment. I won't get into all of this because I know that others are going to go into all of these other strategies that are non-medication related, but needless to say, medications aren't the only option. There are a host of migraine preventive medications that have been out on the market for a long time, that have been used for other indications for a long time. And so I just wanted to highlight the fact that there are these strategies that have been out there for quite some time. And these medications, we have a lot of information about. We tend to start low and go slow as the first strategy. We tend to want to keep patients on their medications for a decent period of time before we know that it's going to be effective if patients don't respond right away in terms of their headache frequency to the medication. We tend to like to monitor the headache frequency with a headache calendar. Sometimes that can be cumbersome and laborious. It really does depend on the patient. Most patients know when they respond to a medication, it's either making their headaches better or not. But sometimes we like to collect some headache calendar data to see what the trends look like. Medications like tricyclic antidepressant medications like amitriptyline, for example, can be helpful. Certain medications like beta blockers, propranolol, metoprolol can sometimes be helpful. And certain anti-seizure medications like topiramate and divalproex have proven efficacy, although there are issues in terms of pregnancy, and you can have issues like neural tube defects with divalproex, or cleft lip palate defects with Topamax in those that are planning pregnancy. So these are things that one has to think about as well with a lot of these medications too. For chronic migraine, those patients that unfortunately meet criteria for having 15 migraine headache attacks per month, that have not, whose migraine headache attacks have not responded to some of these other preventive medications, one can try onabotulinum toxin A or Botox for the treatment of chronic migraine. This is given as a series of injections in the head and neck every 3 months. there is proven efficacy for Botox for the treatment of chronic migraine. And so again, this isn't a new strategy, but one where there is proven efficacy. So the newer medications, well, again, targeting CGRP, right? That peptide. So we have abortive medications, and now we have preventive medications. So we now have antibodies where you can actually inject once a month using a pen and target either the CGRP molecule or the CGRP receptor to reduce CGRP transmission and decrease headache pain. And what's interesting is that not only have patients found a reduction in headache, but also a reduction in associated symptoms and disability. What's nice is that patients really have very few side effects related to the CGRP antibodies, and it's once monthly injection. So they have much fewer days that they actually have to take the medications. So a lot more flexibility, I think, with this as compared to other medications. And then there's also some infusions that patients can get as well. But the once monthly injections have actually proven to be very beneficial for some patients in terms of flexibility. So these are the newer medications, and there have been a series of clinical trials. Different companies have put out different antibodies that can be tried. Constipation, injection site reactions have all been documented as side effects, but really patients seem to have responded quite well. And I think that it's been a real triumph, quite frankly, that we've gotten to the point of having these selective antibodies. And it's demonstrated that we've gotten to the point of understanding more about mechanism to be able to generate disease-specific drugs for prevention, and gone beyond disease-specific drugs for acute treatment to disease-specific drugs for prevention of migraine. And I think that that's really what we're learning about about the story of the antibodies. And this is for both episodic and chronic migraine. There are a host of devices. I'm not going to spend a long time with this because I know that I'm sort of out of time here, but there are devices for people that do not want to try medication. So there are things like STMS, or transcranial magnetic stimulation. This is a stimulator that goes on the back of the head. So you kind of hold it on the back of the head, and it can be used for acute attacks. And it can be used if you have other stimulators and pacemakers and things, but it's mostly used for people that have migraine with aura, but that's one option. There's the Cephali device, you know, I shouldn't say Wonder Woman, but there's the Cephali device that goes across the forehead. This can be used for also acute and preventive treatment as well. And that's demonstrated some efficacy. I think we probably don't use neuromodulation enough. That's why I wanted to put this in here for those that aren't really thinking about medications and want to know a little bit more about the devices. The vagal nerve stimulator stimulates here at the vagus nerve area. There is a protocol for acute and preventive treatment. The combination of clinical trials together demonstrated that there may be a signal of efficacy for migraine. So that's neuromodulation there. And then the newer one is a Nervio device. It fits like a band, sort of, that goes around the arm, and it stimulates this area here. It produces electrical stimulation, remote electrical stimulation on the arm. So there's a new device out now called the Nervio device. And then in the future, and this is my last slide, we're probably going to target a host of other neuropeptides. There are other neuropeptides like CGRP. Those neuropeptides are neuropeptides like PACAP. It falls in the family of CGRP. And in other words, it's likely a pain producing protein. There are neuropeptides like oxytocin that acts inside the brain and one of the centers in the brain, the hypothalamus, that may be hyperexcitable during migraine attacks. We're always thinking about ways in which we can deliver drugs better. So nasal sprays, for example, instead of pills. Sometimes people have problems with, swallowing the pills, and all of that can be really problematic. So how can we deliver things better? transdermally, nasal sprays. There are even new ion channel blockers that we're thinking about. These channels are ones that open and allow excitability of nerve cells, and new devices. So all of these things are things that we're thinking about for the future of headache, migraine treatment. So I'll end there. Sorry if I went over a bit, and I'll take whatever questions you guys have.
Oops, that's okay. So we are 5 minutes over. So here's my thought. We are going to take a 5-minute break, just so everybody can jump up and stretch for a minute. Dr. Harriott, there's 2 questions in there in the chat, which I'm sure you can see too by clicking on chat. Do you mind sometime just over the next hour and a half if you just jump in there and answer? Could you answer that by chat?
I'll do that. Absolutely.
Does that work? And then we'll take a 5-minute break. So we'll come back at 2:10. And that's when Meredith Starr will start. Does that work for everybody? And we'll reconvene at 2:10. Thank you so much. That was so wonderful. I loved hearing about all the medications and that we're even getting some new medications. So I enjoyed your presentation so much.
Thank you.
Yep. We'll see everyone back in 5 minutes.